during the presentation. So, Dr. Sami, thank you very much for presenting today. You can start whenever you are ready.
Hi, thank you. Thank you very much. Good afternoon, everybody. I'm happy to present here in this great forum. My name is Sami. I'm a trauma and acute care surgery fellow here in Miami, Ryder Trauma Center, from Israel originally. The case that I'll present today would be a case of a gunshot wound to the back with a retroperitoneal hemorrhage with an interesting course. And I'll start with the case right away. Can you see my slides properly?
Yeah, we can see it.
Excellent. So we're going to discuss a little bit through this case about the management of complex abdominal and retroperitoneal gunshot wounds, talk about the operative and mostly the non-operative techniques and considerations, and management of the post-op complications. So let me just downsize this a little bit so I can see. So this case happened in Ryder just a few months ago. We had a 25-year-old patient came in. Trauma alert was a gunshot wound to the right flank. Per the EMS who brought him, the patient was a GCS of 15. His heart rate was in the 70s. He was borderline hypotensive en route with a systolic blood pressure of 90. No known past medical or past surgical history. No known medications. When the patients arrived, he was protecting his airway. He was talking, though he was in pain. He had bilateral breath sounds. He was saturating 95 on room air. His initial blood pressure was actually quite high, 185, but he was tachycardic to the 115. His neurological exam was fine as a GCS of 15, and upon exposure we saw a gunshot wound, actually an aperture to the right flank. On the secondary survey, again, airway patent, remained Glasgow coma score 15. He was warm. And you can see here in this diagram, this is the area where he had the gunshot wound to the right back, to the right flank. This was his initial labs. He had a pH of 7.4. He had a base excess of -1 and a crit of 39. His hemoglobin was 13.7. And this was his abdominal X-ray. And what you can see in this abdominal X-ray, you can see probably what looks like the bullet in the right side of the abdomen / back, and a few fragments probably of this bullet lodged somewhere there in the abdomen / retroperitoneum. At this stage, we really don't know. So at this point, I would open the debate to the panel.
Sure, thank you. So let's start with Dr. Untracht. So Dr. Untracht, what would you do in this situation? What would you do next?
Yes, so patient relatively stable, shot in the right flank. And at first, when the first vital signs showed a pulse of 70 and systolic blood pressure of 90, I was concerned about possible neurogenic shock due to injury of the spine, but that doesn't seem to be the case. It seems like maybe he's tachycardic from pain. And his abdominal exam, you didn't mention, but because he's stable, I would think that you can put a couple of IVs in, Foley catheter, and do a CT scan of the abdomen. That's what I would do next.
Perfect, thank you. Dr. Kassim, could you add anything to that from Dr. Untracht?
Well, injury to the flank area on the right side. What should you be worried about? You should be worried about injury to the kidney, injury to the ureter, injury to the duodenum, injury to the right colon, and possibly if the fragment gets dispersed, it could injure anything. So, but mainly you will be concerned about the urinary tract, right colon, and the duodenum. So you resuscitate the patient according to the ATLS protocol. You give him a little bit of fluid and put a Foley catheter in to see if there is any blood in the urine, and re-examine him and see if he's got any peritoneal signs. And then now what I would do is I probably will send him to the imaging center, where I would specifically will request after the KUB, and I also get a chest X-ray to make sure that the chest X-ray looks benign. I would specifically will request a CT of the abdomen with oral contrast, IV contrast, and also if my friendly radiologist is helpful, I would ask him at least, should I also do a rectal contrast to see if that would get down to the right side of the colon. And that's what I would do, but others would probably will disagree. We'll see what others would do. Thank you.
Great, thank you. So resuscitation and triple contrast abdominal CT scan, right? So we also have Dr. Gustavo Fraga from Brazil. Dr. Gustavo, do you want to make additional comments? You're muted, Dr. Gustavo. Yeah. No problem. We will wait for you. Dr. Hochman, do you want to make additional comments? Dr. Varon, I see that you are also online.
I think that, yes, this patient is hemodynamically stable. You can do a CAT scan. It will give you more information. I will add to the injuries that Dr. Kasim mentioned, vascular injuries like the IVC or the renal vessels. But I think it's also this patient can go straight to the operating room, because this patient will need to be operated, almost sure. The bullet, I am willing to bet, was a jacketed hollow point, and the inside of the bullet tends to be lead or some material similar to lead, and the outside is copper, and it mushrooms when it hits the tissue, and those are the sharp fragments that you see all around, and that can cause more injuries distal to the main injury. So in the colon, probably can go through into the colon, and maybe the whole seal itself, maybe not, but in a vessel would not, and the vessel will cause more bleeding. So, and this is very dangerous for the surgeon when you go in, because it's very easy to cut your fingers trying to feel for stuff. So yes, depends on the situation. I would probably scan the guy first, but depend on my mood, I would take him straight to the operating room, because this guy needs to go to the operating room. Thank you.
Great, thank you. Very interesting comments about the ballistic project. So, Dr. Gustavo, your microphone is okay
yes,
now.
Can you hear me?
Yeah, we can hear you.
Okay, thanks so much. Good afternoon. My opinion, it's a surgical patient. This patient needs a surgical treatment. Some information, maybe additional information, is good to prepare the patients for the surgical treatment, like the urinary catheter, if you have blood or not, rectal examination, if you have blood or not, so you can estimate what injuries the patient has. But I think the patient is stable. You can have a CT. You can have a CT first. our experience here in Campinas without rectal contrast, only IV contrast, because it takes long to put the contrast. So only the IV context, and we prepare the OR for surgical treatment. Prepare our team, because I don't remember about the abdominal examination of the patients, if the patient has pain or not, but probably with the X-ray, this patient has intraperitoneal injuries, so he needs surgical treatments. Let's wait for the next steps.
Perfect. Thank you. Dr. Sami, do you want to proceed?
Yeah, so actually I didn't want to give away too much detail, so there will be like a good discussion. But in further examination of the patient and further examination of the abdomen, it seemed that he's has significant tenderness and actually quite peritoneal. Also, when re-evaluating the blood pressure actually dropped to the 90. So it became obvious to the team that these patients with the gunshot wound to the abdomen, as well as the peritoneal signs and developing hypertension, there's only one way, one place he needs to be right now, and this would be the operating room. So we actually took him to the OR. Even though at first when he arrived, I agree with all the panel and his initial hemodynamic status, we also thought about taking him to the CT first. So we took the patient to the OR, performed the laparotomy.
Can I make a quick comment, Dr.
Yes.
Ginsberg? I was not there for the first part of this case. I was there for the decision making on the second part. But really, the discussion on the use of CT scan in this patient preoperatively, we, in fact, published in 1994, I think it was first time published, the use of CT scans for gunshot wounds, and it was really just to see if the bullet was tangential and did not penetrate the intra-abdominal cavity. And so in this case, you could have done a lateral KUB on the patient, and you could have found whether the pellets were inside the belly or not if he came in without abdominal pain. If they remain posterior, or if there was a question of them entering the peritoneum, then the CT scan would have been indicated. But obviously, he had abdominal pain. Now, as you will see, I'll make a comment about what I just said in this particular case, because there's a caveat.
Okay, thank you, Dr. Ginsberg. So we took the patient to the OR, performed the midline laparotomy. We encountered two small bowel injuries. One was quite proximal to the mid-jejunum, and one was quite distal to the distal ileum, about 15-20 centimeters from the ileocecal valve. We further explored the abdomen. We saw a right zone 2 hematoma as expected, and we elected to explore this hematoma. We performed the right medial visceral rotation. We identified the ureter. It seemed to be intact. And what we saw was what looked like a defect or a hole in the psoas muscle that was oozing, looked like a mild venous oozing. We decided to put in a nunit, a rolled nunit. A nunit is like some sort of a hemostatic agent. It looks like a gauze, actually. And we just put a rolled nunit inside this hole in the psoas that was oozing mildly and put a lap pad over it. Also, when we further examined the abdomen, we saw some mesenteric defect around the cecum mesentery that was bleeding. We put a few sutures. It looked fine. but we decided to leave him open to perform a damage control surgery, to leave him open and take him the next day to look again at the area when there was a mesenteric injury, and close him perform anastomosis and close him on the next day. So the abdomen was left open. The patient bowels were left in discontinuity. He was behaving fine throughout the surgery. He managed to receive 1 unit in the resus before he was taken to the OR. He received 1 more unit during the case and 2 units of FFP. And he went to the trauma ICU from the OR.
Why was the patient left open during that first case? He only received literally 2 units of blood.
Yeah, so I think the main injury was the mesenteric injury to the cecum. This was the main concern, to look again in 24 hours to see that the iliocecum area is viable and then close him. Otherwise, I agree, you should have been, there was no other indication not to close him. But since we elected not to close him and leave him open, we put 1 lap pad there over the unit.
But you say the cecum is viable?
Yeah, the cecum looked viable. There was a little bit of bleeding from the cecum mesentery that we sutured and a small defect that we sutured. It looked okay, it looked viable. But again, because of this injury, we thought he would benefit from a second look on the next day.
Was the right colic artery intact?
Yeah, it seemed to be intact. The bleeding was probably like a venous bleeding. So we took him the next day. After 24 hours, took off the dressing. The bowel seemed viable. We performed 2 hands-on anastomosis where we resected the 2 pieces of small bowel, 2 segments of small bowel. We looked again at the cecum, and it looked viable and well perfused. We looked again at the right retroperitoneum where the pneumonite was placed. We removed the lap pad. It appeared hemostatic. The bleeding that was there before seemed to be stopped. We applied, just as a precaution, some Vistasil, again, a hemostatic agent, over the right retroperitoneum and over this area that was bleeding before. And we closed the abdomen, hoping not to get back to the abdomen ever again. Definitely close him. So the patient was initially doing fine. He went to the TICU, but then on POD, postoperative day 3, he became hypotensive. His abdomen was distended, but still soft. He wasn't peritonitic. It was just distended. It was actually extubated the same morning and was mentating quite okay. We got some more history from the family. It seemed the patient was a chronic drug user, heroin user, on like painkillers daily. But as I said, a few hours after being extubated, the patient developed hypotension. Abdomen was a little bit distended, and in serial trending of hemoglobin, it seemed that hemoglobin has dropped from 8.5 to 6.2. And what's next?
Great, thank you. So just a quick question before calling the panelists. So in the first surgery, the bleeding, the oozing, you thought it was coming from the muscle, the iliopsoas muscle?
Yeah, we didn't identify any specific vessel bleeding. It looked like it was bleeding from the muscle. It was where probably the bullet was stopped, or bullet or fragments in the psoas muscle. And it was just mildly oozing, and it seemed to be, by the next day, it seemed to be stopped.
Great, thank you. Dr. Kassim, do you want to make some comments?
Well, I think I have the same, I got the same feeling as Professor Ginsberg there. You know, that he didn't receive too much fluid, and, you know, why all this drama? But, you know, there's always several ways to skin a cat, they say. And Ryder is a world-renowned surgical center, and they know what they're doing. So they probably saw something that I don't appreciate sitting here. So that's fine. So they did the right thing, and they took the patient to the intensive care. And all this drama started to occur after they extubated the patient. So I don't know what the rush was to extubate him. Again, yeah, I'm just wondering, you know, why would you extubate a patient and then very quickly he goes south? But right now I'm convinced, looking at the his blood work, etc., that he's bleeding. No question about it in my mind. And I would not do anything further at this moment because it is becoming urgent to me. And I would return him back to the operating room to find out where exactly he's bleeding from. It may not be from that hole in the psoas muscle. It may be from somewhere else. You know, it could be an IVC or something that we are not appreciating. So it is imperative that I attach some type of urgency to this case. Otherwise, I'm going to lose him, and I return him back to the operating room immediately with some blood product on board and FFP, etc., so that I can re-explore him to see where the bleeding is coming from. Thank you.
Great, thank you. Dr. Gustavo, Dr. Kassim is very concerned about the bleeding. Are you, do you share the same concern? Are you willing to do anything different?
Yes. First, I have a question to Dr. Sami. How was the surgical team feeling with this patient? Because the patient was operated after 24 hours. The second, I think there was a little ischemic because was not resected, but was bleeding coming from the retroperitoneal. Have you explored all the retroperitoneal about the vessels, the duodenal, everything was explored, no injuries were detected. It's very important. And during the reoperation, they found again bleeding. There was an injury in the small bowel that was resected. Interectomy with the anastomosis. In the first surgery, did you suspect of this ischemia in the small bowel to justify this resection? And now you have a problem because after 2 surgeries, the patient has something wrong. Something is going wrong with this patient. Probably need another operation. But what did the team? Was the same team that operated the first and the second surgery, the same surgeons, like Dr. Ginsburg, experienced surgeons, no missed injuries, probably. What do you feel, Sami, after this, at this moment? What was your feeling?
Yeah, so Thank you for the question. I'll answer all of it. So first of all, regarding
Sami, I hate to interrupt. Why don't we ask Dr. Utrecht before you make any comments on the questions of Dr. Fraga?
Okay.
Yes, well, Dr. Untracht and Dr. Hockman, but
And
what do you want me to answer? I wasn't there, so I don't know, but I agree with everything that Dr. Fraga said, and I'm assuming that you had a very good exploration. You did a thorough examination of the duodenum, the retroperitoneum, everything was okay, and you ran the bowel, you looked at the upper abdomen. So I assume that all that was done, and you said there was really no bleeding when you went back the second time. You know, and the case is complicated by the opioid use disorder. So he's on Suboxone. So apparently he might have gone through a little bit of withdrawal, and that might be a complication here. If he, you know, if he had a distended abdomen, an ileus related to the opioid use, and that's why the abdomen was distended, but there was no rebound tenderness, and he had a lot of pain, that there may be some confounding factors because of the opioid use. So, but nonetheless, I think you have to assume if the hematocrit is dropping acutely, that he's bleeding, that it's not just equilibration from postoperative fluids, and now he's hypotensive. So, you know, I think all those points that Dr. Fraga makes are good, but it's a bit academic because in this setting, I agree with Dr. Kassem, patient really should be re-explored. You know, you can look for pneumoperitoneum or put an ultrasound to see if you have a blood collection anywhere. But I think probably safest place is to go back to the OR.
Dr. Hoffman.
Yeah, I agree. I think the patient needs to go back to the OR. And regardless what you found the first time, you are going to find something else. Whoever say that never had a patient who bled postoperatively probably didn't operate enough. We all have patients like this that we are completely sure everything is dry, and suddenly we go there, and sometimes we find a completely unexpected source of bleeding, and sometimes we don't find anything. We find 2 liters of blood and we cannot find the source. But I think this patient at this time is probably too sick not to go back to the operating room. Thank you.
Great, thank you. Dr. Sami, do you want to address the questions?
Yeah, so just to address a few of the questions regarding the small bowel injury, it was an obvious injury to the bowel itself, so it has to like a full thickness bowel injury from the gunshot wound, from the guns. So it obviously had to be resected. It wasn't like a mesenteric injury or a bucket handle injury. It was a direct injury to the bowel, so it had to be resected. Regarding the exploration, we felt good about the exploration. Like it meant, I didn't mention it, but we looked at the duodenum, we looked at the retroperitoneum, we identified the urethra. We felt good about this exploration. And also another comment made here was whether or not it was the same team. So actually, it wasn't the same teams. In both operations, there was an attending. There was like a very experienced attending in both of the operation, but both the fellows, the resident, the attending was completely different team. Part of it is because how we operate here in Ryder, so we changed the team. So this initial operation was done at the evening, and then after 24 hours at the next evening, it was a completely different team. But yes, so we thought about what to do next. Actually, I agree that my personal thought was also to take him back to the operation room. But we
let me stop there, Sami, okay? For 1 second.
Sure.
So this is where can someone mute? This was where actually my involvement in this case came at this point in time. So I'm the third attending with a patient who we checked the hemoglobin just to make sure. It was 6.2. His belly was distended, a little bit tight. The tenderness, we sort of couldn't tell whether it was real or not because of his heroin and his mother saying that he gets abdominal pain when he's detoxing. But at that point in time, for me, the most important lesson, other than the subtleties that you'll soon find out, was I actually called up the second team because I posted him for surgery. But then I called the second team. And by the way, if I remember correctly, he wasn't even acidotic. He responded to a unit or two of blood. And I called the second team that operated on him. And during the second operation, because I was told that he had a large mesenteric hematoma, so I thought this was the source of his bleeding. But when I spoke to the person who was there, Dr. Abbas, who was supposed to present this, Sami was there during the first case. Sami, you can correct me if I'm wrong. But with everyone, after speaking to Abbas, he told me that there was no hematoma in the mesentery. Everything looked clean, but there was some oozing in the psoas muscle that they just put some more Surgicel in. So at that point, I had a relatively stable patient, which I knew I would need to take to the OR, but I suspected something, and I'll let Sami take over at this point in time of what we did.
So
Great, thank you, Dr. Ginsburg.
yeah, we like to take the patient to CT. And I'm showing you the CT abdomen right now.
Now, the reason we took him for CT of the abdomen is that I've done a lot of spine approaches. I don't know how many of you have done the spine approaches for your spine surgeons, where you mobilize and dissect. And my biggest suspicion when they told me about the psoas was that he had a lumbar artery injury. And if any of you have ever had to deal with a lumbar artery injury, when they're injured, they retract. And you're going to have a hell of a time trying to get control of them. And that's the reason we took this approach of getting the CT first.
So this,
Was it with contrast, doctor? Did you
I
use
asked for contrast, but he didn't get contrast. But that's okay.
Yeah, it was meant to be a CT angio, but it ended up being not a CT angio. So this CT showed, as you saw, hemoperitoneum, but it didn't show any specific extravasations, as it was not eventually CT angio. So again, we were left with this CT.
No, but there was a suspicion. Take a look at the spine films in the CT as you go down. You see that hematoma right there, and the bullet fragment.
Yeah.
So at that point, I suspected a lumbar artery bleed, pseudoaneurysm. So go ahead, Sami.
Ginsburg, Dr. Ginsburg. Dr. Ginsburg, may
Yes.
a question, please? Have your team discussed with the interventional radiology or vascular surgeon
yes.
to embolize this bleeding?
That's basically, you'll see when we got the CT, then my suspicion was even more. So then Sami will tell you we ended up. Go ahead, Sami.
Yeah, so now with the suspicion, as Dr. Ginsburg said, of maybe a retroperitoneal hemorrhage originating from a lumbar artery injury, our next step was to speak with our interventional radiologist colleagues and ask them to take him to a procedure to perform an angiogram and possibly coil embolize what is bleeding. So that was our next step. This patient went to IR the same evening. They saw right L3 lumbar artery pseudoaneurysm, as well as an active extravasation from the L4 artery, and they performed a successful coil embolization of both the arteries, the L3 and the L4. I think I even have a, let's see here, the extrav. I think I even have a film here. Yeah, this. Yeah, so you can see the active extravasation from the L4 artery. Sorry. And after it was coiled, it seemed to be hemostatic and not bleeding anymore. So the procedure seemed to be successful. Both the arteries, both the arteries were coiled, but unfortunately, since the patient went extubated and has removed his NG tube during the extubation period, while lying there during the procedure, he vomited and seemed to be aspirated. And while returning to the ICU, he was hypoxic and had to be re-intubated. So the patient was now, and the plan was to take him after this successful IR procedure. So we can talk about it, and I can ask the panel, is this enough? Do we need to take the patient to the OR after successfully embolizing the arteries? We stop the bleeding.
Sure. Quick question for every one of the panels. Dr. Untracht, would you follow this suggestion of taking the patient to the OR after the embolization, or would you not?
Well, yeah, not necessarily. It depends on how he does. I mean, that volume of blood, it was moderate. And, you know, after somebody ruptures an aneurysm, there's that much blood left in the abdomen, you know, that gets reabsorbed later. But it depends on, you know, he's got, if his pneumonia resolves and then his ileus resolves and he's doing well, then, you know, not necessarily, but it's a judgment call at the bedside.
Great, thank you. Dr. Kassim, do you have a different opinion?
I don't like to leave behind a large hematoma in the abdomen, especially after 2 previous surgery, because in my experience they always get infected, and then I cry. Why didn't I do drainage of that? So I guess I'm a little more aggressive than other people. I probably will take him back to surgery, quickly evacuate the hematoma and close them up, and then treat the aspiration pneumonia vigorously. Thank you.
Great, thanks. Dr. Hochman, do you agree? Would you do anything different?
You cannot argue with success. This works, so I cannot argue. My only concern is if the artery was injured, the vein was probably injured too. And having been there, yes, the artery bleeds more, but the vein is usually more difficult to control because it retracts even more than the artery. And it's very difficult to put the stitches in that area. The other concern I have with embolization, which in this case work, there are collaterals. So even if you embolize one artery, the other end might be bleeding from collaterals from the other side. But again, in this case, work. So I cannot argue with success. Those are things that are popping in my mind, but this is the beauty of this conference. We can find that we can solve the same problem in many different ways. Like Dr. Kasim say, many ways to skin the cat. I probably wouldn't take him back to the OR to evacuate the hematoma. I left bigger hematomas inside, and as Dr. Untrak mentioned, he get reabsorbed, and I probably wouldn't take him back. But again, I'm pretty sure that you took him back, and I will be wrong. So let's see what happens.
Thank you very much. Yeah, I think that I'll be a little bit concerned as well as regarding abdominal compartment syndrome, maybe because this patient is bleeding, he's very inflamed, he's receiving a lot of fluids from transfusion, and also I think it's another concern to consider. Dr. Ginsburg, any additional comments in this part of the case?
Yeah, the plan on this patient and some of the subtleties that didn't come out possibly for all of you. I know you all masters, was that if you remember, his belly was a bit tense, and he was complaining of abdominal pain. And so for me, it was always, he was going to go to IR to get control of those vessels, if I was right, the pseudoaneurysms, get him angioed and get him straight to the OR. Initially, I was trying to get them to do IR in the OR, but they said that they would not be able to get good therapy. If he needed something, they wouldn't have been able to do it in our modified hybrid OR due to our equipment not being as good. So it was kind of a touch and go. He was stable enough, I felt, for him to go to IR and get the procedure. And so he was supposed to come back and go straight to the OR to also not just evacuate, as pointed out, it was a significant amount of blood and he was a bit tense, the abdomen, but also to rule out any, bowel ischemia, because he was having some abdominal pain also. So that was the decisions. And at that point, when I'll let Sami take over.
Great, thank you. Very interesting.
Like Dr. Ginsburg said, that was the plan. We discussed it again at morning report, and we decided to take the patient back. He remained hemodynamically stable. His hemoglobin was stable, but it seemed that he had this distension. He required high ventricular support, probably because of also as his aspiration pneumonia. And we decided to take him to a laparotomy the same morning. We took him. We opened the abdomen. As expected, there was a large volume hematoma there, approximately 1 to 1.5 liters. We washed the abdomen out. We explored everything, as well as the retroperitoneum. We explored the bowel. The bowel seemed viable. Both the anastomosis seemed viable. The colon seemed viable. And the retroperitoneum seemed to be hemostatic with no further bleeding. We did put some hemostatic agents there, like as a prayer or a precaution over the right retroperitoneum, but there was no further bleeding, and we definitely closed the abdomen. Just to sum up on his postoperative course, so he had no further bleeding episode. As expected, he had some infectious complications, also had a pulmonary emboli, for which he was started on full anticoagulants. But by the way, I didn't discuss, and it wasn't, the panel didn't ask, but we started this patient on Lovenox approximately between the two surgeries. So he was started on prophylactic Lovenox 40 BID, as we usually do here in Ryder, about 24, 38, 6 hours after the first surgery. the patient was eventually extubated on postoperative day 10, tolerated diet, having bowel movements, and eventually discharged home. And we saw him again quite recently in clinic. He was doing actually quite well. Just to sum up, just 2 slides about lumbar artery injury, and then I'll be happy for some closing remarks by the panel. So the management is quite challenging, and there is limited literature. We looked at the literature. Actually, most of the scarce literature comes from spinal surgery and iatrogenic lumbar artery injury that they encounter in spinal surgery, and there's very little literature about the management of lumbar artery injuries. It's mostly case reports and small series. There is the latest one is an article, a retrospective review of 10 years of an Australian team experience that was published in 2022 in Injury. So the mortality rate, we don't know what's the mortality rate. Again, there is no, in trauma, there's not only a solitary lumbar artery injury, it's always a multi-injury. So we just know that the retroperitoneal hemorrhage mortality rate can be quite high. They did know this in the latest series that was published in Injury, that there is high association with transverse process fracture and higher ISS and shock and the need for massive transfusion protocols when you compare it to other sources of retroperitoneal hemorrhage. So this may serve as a hint or a clue for a possible lumbar artery injury and should raise a suspicion. I remind everybody knows the retroperitoneum is highly vascular, multiple collaterals with lumbar artery collaterals arising from superior and inferiorly. This is, of course, the anatomy. You can see the lumbar arteries originating from the aorta and then above the posterior intercostal arteries. Regarding the management, from the little literature that I saw about it, surgical hemostasis, and if anyone from the panel has some experience with open surgical hemostasis of lumbar artery injury, we would be happy to hear. But surgical hemostasis is very difficult to achieve. It's difficult to achieve proximal control, difficult to visualize the bleeding vessel. In addition, the exploration of the retroperitoneal hematoma can cause this decompression of the bleeding and the loss of tamponade effect. The little of the literature agrees that angiography, angioembolization is probably the preferred modality of treatment, with success rate reported as high as between 70 and 90%. And some of the literature, even they recommend if angio is unavailable at your institution, they would prefer conservative treatment with resuscitation over surgery and trying to do surgical hemostasis of this bleeding vessel. One always has to remind us that there are complications to angioembolization. They are rare, but one of the complications is embolization of the artery of Adamkiewicz that supplies the spinal column, and it has been described. Actually, I myself, I saw an artery of Adamkiewicz accidental embolization when trying to, in another hospital that I worked in, trying to embolize bleeding from an intercostal artery. But the artery of Adamkiewicz also can arise from a lumbar artery, so it was also described as a very, very rare complication. Just an illustration of the artery of Adamkiewicz arising from the artery. And just to summarize, need to have a high degree of suspicion for lumbar artery injury, especially in the setting of retroperitoneal hemorrhage, and as well as a pelvic and spinal trauma in patients with retroperitoneal bleeding. If available, consider IR as a go-to modality for embolization. And regarding the open surgical hemostasis, there are some surgical pearls of how to try to control it, but again, they are very, very challenging to control. And that's it for me.
Great, thank you, Dr. Sami. I will run through the panelists now for the final comments. Dr. Kassim, do you want to make final comments?
Well, I'm glad I joined this meeting today because I really appreciate Dr. Ginsburg to throwing me some pearls. I've never seen this before. I have seen something like this in the neck with vertebral artery injury, and it retracts back and it stops the bleed and declares itself with significant hemorrhage from the drain in that area after neck surgery. But I have not encountered anything like this in the lumbar area following gunshot wound. So this will go into my hard drive and with Ginsburg name on it. And thank you, Professor Ginsburg, for teaching me something really, really good. I enjoyed that very much. Great call. Thank you.
Thanks a lot. Dr. Hochman, any final comments?
As I said before, you cannot argue with success. Just a few words of cautions about some things that were in that paper that you described. The tampon up is effective when you don't have a hole in the retroperitoneal. You don't have tamponade here because the retroperitoneal is open. You have a hole. So might not work, it might work, but it might not work. Yes, retroperitoneal hematomas, very rarely we operate unless they are open. The same thing like pelvic hematoma. We don't operate, but when they are open, we have to do something. And so that's to take into consideration. Regarding the approach, yes, in the left side, you can get the aorta posteriorly. On the right side, which is this case, is very difficult because you have the IVC in the middle. So it's very, very difficult to get it that way. So the trick is to do a digital compression of the IVC and go in between the IVC and the aorta if you cannot get it. But it's very difficult to get access there. Very, very difficult. So anyway, so that's it. That's the only thing I have. But congratulations, Dr. Ginsburg. Really, it shows the experience of a surgeon who kind of made the diagnosis by looking at CT where nobody would have seen anything and say, oh, this is probably what it is. And this is years of experience for the junior people. This is a very good opportunity to learn from the masters. Thank you.
Awesome, thank you. Dr. Untracht, do you want to make final comments?
Yes, great case. Just to follow up with what Dr. Hochman just mentioned, although for a zone 1 hematoma, they usually get operated on, don't they? For zone 1, as this was.
This was more as zone 2, actually.
Zone 2. It was zone 2. Okay. All right. Well, anyway, but great case. A very unusual injury and brilliantly diagnosed and handled just magnificently. And I learned a lot. Well done.
Thanks. Dr. Ginsburg, any comments? Any final comments?
Yeah, what Dr. Hochman said, you know, if, the comment about not operating on these, usually you end up having to operate on lumbar artery injuries that continue to bleed. Luckily, you know, this was, you know, as I get older, you know, even though I didn't do one surgery on this gentleman, the enjoyment was on the diagnostic and the experience of having to do a lot of spine surgeries in the past and having to stay away as for those of you who have done them. And as Dr. Hochman said, you got to stay away from those little vessels when you're mobilizing for the spine surgeon. And I actually have to divide those for them. And so it's always sort of, that's the part of the surgery that's the most stressful. so that you don't lose control. So for me, the take home is talk to the surgical teams if you're coming on, because what people tell you that weren't there is not necessarily accurate. So you'll get the accuracy. That's number one. And then number two, go with your gut feeling. Believe me, I had a lot of people telling me to take this guy straight to the OR. And if I would have done that, that guy would have ended up with probably 5-6 unit bleeding, inability to control, and having to get IR posted ipso facto anyway. So that's really it. And I hope you enjoyed it all with respect. This is, by the way, this is my first that I can remember lumbar artery trauma injury, but not my first experience with lumbar arteries.
So if I may add to what Dr. Ginsburg said, Dr. Ginsburg, that was not gut feeling. That's a pattern recognition. We call that gut feeling because we recognize patterns with the right side of the brain. This is a topic that fascinated me for many years. I'm sorry, I'm digressing a little bit, but we really have two brains. Somebody won the Nobel Prize describing the splitted brain in patients with epilepsy, that they were transecting all the connections between the two hemispheres to prevent the seizures to becoming generalized. And when they realized that we have two brains that are connected, but really they are two completely separate brains. And the pattern recognition happened on the right side of the brain, which is nonverbal. So that's the reason when you have to say, Dr. Ginsburg, why did you know that this was this? You come out, well, it's a gut feeling, because it's very difficult to verbalize how you recognize this. And I disagree with you. You're not getting older, you're getting more experience. And with experience, you get this pattern recognition. And for the juniors, you will see many times seeing an experienced surgeon doing something that looks completely crazy. Why you're doing this? Well, it was a gut feeling. It's not a gut feeling. It's having seen hundreds of cases over years that allow you to recognize that unusual pattern that is very difficult to describe. And that's the value of the experience. For the juniors, don't try to do that. Follow the rules, because you will have more chances of success. But for the seniors, they did a very fascinating study with airline pilots. They got the senior pilots to write the rules for the junior pilots. And when the junior pilots applied the rules, they became more proficient. But after that, they went to the senior pilots and they asked them to do the same, and their proficiency decreased, because they are paid by the expertise, not by following the rules. So this is what happened in this case, is the experience of having seen hundreds of cases, that suddenly you feel that it doesn't feel right, but you cannot explain why, because the right side of the brain is nonverbal. Sorry to digress, it was kind of like, it's a topic that always fascinated me, but this is clearly illustrated in this case with what Dr. Ginsburg did.
That was interesting. One more comment for residents or juniors here. There was one complication that occurred that would have possibly been preventable, and it was so simple, and I even missed it, and it was sending the patient to IR with an NG tube.
Without, yeah.
No, I'm saying if I would have sent him with the NG tube, there was a possibility that he would have not aspirated. So even the smallest things turn cases into big things.
Yeah, thank you very much. The comments were great, and also this neuroscientific lecture from Dr. Hoffman was really interesting as well. And I think that the case was really interesting, a lot of learning points, and a great catch from Dr. Ginsburg and all the team. And I think that is a very interesting case. So the recording is going to be available for everyone in the PTS website, so you can watch again as much as you like. And that's it. I thank you very much for being here, everyone. Thank you, the PTS, for having me as a moderator. I'm always trying to do my best here, so I thank you very much for for the help that you've been giving me here in the moderating session. Dr. Sami, thank you very much. The panelists, thank you very much as well for the comments, and we'll see each other again in the next meeting. Bye-bye.
Carlos, you're doing great. Thank you.
Thanks a lot, Dr. Hassim.
Thank you.